Imagine just breaking free from a really debilitating illness, actually getting your life back, a second chance. It sounds incredible, right?
It really does.
And that's often the promise of kidney transplantation. But, it's not just one surgery. It's the start of something much bigger, a really profound and fascinating journey.
Absolutely. A very personal one, too.
So today on the deep dive, we're really going to look closely at kidney transplantation. We want to go way beyond just the operating room, look at the intricate science, like how the new kidney actually works and, well, how the body sometimes tries to reject it.
That immune response.
Exactly.
Yeah.
And the lifelong medical stuff involved, and crucially, what daily life is really like, the ups and downs, the emotions for people living with a transplant.
Right. The lived experience.
Our mission here is to give you a really full picture packed with key insights, real-world details, connecting the science to the human side of it all.
And we've got some great sources for this.
We do. We're pulling from comprehensive reviews on the drugs, practical patient handbooks, detailed medical overviews, and even some fascinating qualitative studies about what it's actually like day to day.
Yeah, those qualitative studies really bring it to life.
Okay, so let's start with the why. For so many people, end-stage kidney disease, ESKD, means life hooked up to dialysis machines. It's tough, but there's this other path. So what exactly is ESKD, and why is a transplant seen as, the gold standard?
Right. So ESKD is basically complete kidney failure. Your own kidneys just can't filter waste from your blood properly anymore. Toxins build up, and that's dangerous, potentially life-threatening.
Okay.
And when you compare transplantation to staying on dialysis, it's night and day for many. Transplantation generally offers a significantly better quality of life and, crucially, better long-term survival.
How much better are we talking?
The data is pretty compelling. Studies project that on average, getting a transplant can add about 10 more years of life compared to staying on dialysis.
That's 10 years?
It's a huge difference. It shifts things from just, surviving to actually living more fully.
It really does feel like modern medicine at its most advanced, doesn't it? Organ transplantation. But you mentioned earlier the first successful one was actually quite a while ago.
It was surprisingly early. The very first successful kidney transplant happened in Boston back in 1954.
54.
Yeah. And what made that one work was that it was between identical twin brothers.
Ah, okay. The genetics.
Exactly. Because they were identical, the recipient's immune system didn't see the new kidney as foreign. So, crucially, no immunosuppression drugs were needed, which was good because, we didn't really have effective ones then.
Right.
The real game changer came later, in the 1960s, with drugs like azathioprine and prednisone. These were the first immunosuppressants that allowed transplants between people who weren't identical twins, what we call allografts.
That's the big leap.
It really was. And then, in the 70s and 80s, we got even better drugs, the calcineurin inhibitors. These improved success rates even more.
So, fast forward to today. Where do things stand now with success rates? Are they pretty good?
In the short term, they're remarkable, actually. Here in the U.S., the one-year survival rates for the kidney itself are about 98% if it comes from a living donor.
98%.
And around 93% if it's from a deceased donor. Really high.
That's fantastic.
It is. But what's interesting, and still a challenge, is that long-term survival of the graft, the kidney itself, hasn't improved quite as dramatically. On average, a living donor kidney lasts maybe 14 years, and one from a deceased donor around 10 years. So it shows that the journey definitely doesn't stop after that first successful year. It's ongoing.
Okay, here's where it gets really, really interesting for me, and maybe a bit counterintuitive. Our immune system is designed to protect us, right? Keep out invaders. So why on earth would it attack a life-saving organ that's actually helping? It seems like it's fighting itself.
That's the absolute core challenge of transplantation. Your immune system is just doing its job, its programmed function, which is to recognize anything non-cell, anything foreign, and get rid of it.
Okay.
And it's incredibly good at that job. The rejection process mainly happens through sort of two main arms of the immune system. First, you've got these cells called T cells. Think of them as like the frontline soldiers.
Right.
When these T cells encounter the new kidney, they see its unique identity markers, we call them HLA antigens, as foreign, and they launch an attack.
Direct assault.
Pretty much.
Yeah.
Then the second way is through antibodies. These are produced by other immune cells, B cells mostly, and they circulate in the blood like guided missiles, targeting those same foreign donor antigens.
Oh.
So yeah, your body basically sees this perfectly good, healthy kidney as a threat, just like it would a virus or bacteria.
So if the body is so determined to reject this new kidney, how do doctors possibly manage that? How do they keep it working long term? Sounds like a constant biological tug of war.
It absolutely is. It's a very careful, lifelong balancing act, using what we call immunosuppressive therapies. These drugs essentially work by dialing down or redirecting the immune system's response so it doesn't mount that full-scale attack.
Okay.
They do this in a few different ways. Some drugs actually reduce the number of specific immune cells, like those T cells. Others sort of divert them so they can't get to the kidney easily. And others block the key communication signals that immune cells need to get activated and cause damage.
So multiple strategies.
Exactly. And the biggest challenge for doctors is finding that sweet spot. Just enough suppression to prevent rejection, but not so much that it causes other serious problems.
Right, that balance again.
Yeah. The typical approach, often called triple therapy, usually combines 3 different types of drugs. You've got a calcineurin inhibitor, there's drugs like tacrolimus or cyclosporine, which are really potent T-cell blockers.
Yeah.
Then an antimetabolite agent like mycophenolate mofetil, often called MMF, which stops immune cells from multiplying rapidly. And third, usually a corticosteroid, like prednisone, which is a broad anti-inflammatory and immune suppressor. Those 3 usually form the backbone of long-term treatment.
That's for the long haul. What about right at the beginning?
Good question. Right after the transplant, when the risk of rejection is absolutely highest, patients get what's called induction therapy. This is like a short, intense burst of immunosuppression.
Like a preemptive strike?
Kinda, yeah. It might involve things called depleting antibodies like anti-thymocyte globulin or ATG. These literally deplete or reduce the number of T cells temporarily.
Okay.
There are also non-depleting antibodies that work more subtly, blocking specific signals like the IL-2 receptor, which T cells need. Now, these depleting drugs are great at preventing early rejection, but there's a trade-off.
Always a trade-off.
Always. They increase the risk of infections and also a rare type of cancer called PTLD, post-transplantation lymphoproliferative disease.
Okay, serious stuff.
Definitely. Then for maintenance, long-term, besides that triple therapy, sometimes newer agents are used, things like MTOR inhibitors, sirolimus or everolimus, or a drug called belatacept. Belatacept is interesting. It's a very targeted antibody that blocks a specific signal needed for T-cell activation, and it's actually shown better long-term patient and graft survival in some studies.
Okay, let's unpack this a little. These drugs sound like miracles in many ways, truly life-saving, but like you said, trade-offs. What are the major downsides, the undesired consequences, as the sources put it?
You're absolutely right. It's a classic double-edged sword. The benefit preventing rejection comes with significant potential downsides. They broadly fall into 2 buckets.
Okay.
First, immunodeficiency. By dampening the immune system, you inevitably make the body more vulnerable to attack from other things.
Right.
Exactly. Increased risk of specific infections. We worry about things like BK polyomavirus, which can actually damage the new kidney itself, or cytomegalovirus, CMV, and there's also an increased risk of certain cancers, particularly skin cancers, and that PTLD I mentioned, which is linked to the immune suppression. The intensity of the suppression really matters here.
Okay, that's bucket 1. What's bucket 2?
Bucket 2 is what we call non-immune toxicity. These are side effects specific to the drugs themselves that affect other parts of the body, not directly related to weakening the immune system.
Okay.
For example, the calcineurin inhibitors, tacrolimus and cyclosporine, while essential, can actually be toxic to the kidneys over time, nephrotoxicity.
So they can harm the organ they're meant to protect.
Ironically, yes, it's a risk that needs careful management. Tacrolimus can also lead to new-onset diabetes after transplant, and glucocorticoids like prednisone are kind of notorious for a whole range of side effects. Weight gain, puffy face, bone thinning, cataracts, high cholesterol.
Wow, quite a list.
It is. Even newer drugs like the MTOR inhibitors can cause issues like high cholesterol, painful mouth sores, and problems with wound healing.
It sounds incredibly complex to manage all this.
It really is.
Yeah.
Think about the precision needed. These drugs often have what we call a narrow therapeutic window.
Meaning
Meaning there's a very fine line between having enough drug in the system to prevent rejection and having too much, which causes serious toxicity.
Okay.
So patients need frequent blood tests to monitor drug levels, especially for those calcineurin inhibitors. And then there are drug interactions. So many things can interfere. A common antibiotic like rifampicin can make cyclosporine levels plummet, while an antifungal like ketoconazole can make them shoot up dangerously.
It's a constant chemical balancing act inside the body.
That's a great way to put it, a constant, delicate dance.
Wow. Okay, so that's the challenge after the transplant. Let's back up. How does someone even get to that point? How do they find a kidney and what goes into selecting it given all this complexity?
Right, the journey to the transplant. It usually starts with the source of the kidney. There are two main types of donors, living donors or deceased donors.
And is one better than the other?
Generally, yes. Kidneys from living donors tend to offer the best outcomes, both for the kidney lasting longer and for the recipient's survival. And living donation is actually increasing in the U.S. Back in 2006, nearly half, 47% of transplants were from living donors.
Okay. So what makes someone eligible to be a living donor?
There's very rigorous screening. They need to be generally healthy adults, typically 18 to 70, with a healthy weight, BMI usually under 35, no active cancer or infections, and of course, excellent kidney function themselves.
Makes sense.
Things that would absolutely rule them out include diabetes, uncontrolled high blood pressure, or being HIV positive. And there's also a really important psychosocial screening, making sure they fully understand the risks, are consenting freely, and aren't being pressured.
Crucial. What about deceased donors?
For deceased donors, we categorize them mainly as DBD donation after brain death or DCD donation after cardiac death. To help match these kidneys appropriately, we use a scoring system called the Kidney Donor Profile Index, or KDPI.
KDPI.
Yeah, it's a score based on multiple factors about the donor: age, ethnicity, their kidney function before death, history of high blood pressure or diabetes, cause of death, height, weight, even hepatitis C status. It gives a more objective measure of the likely quality or longevity of the kidney.
So a lower score is better?
Generally, yes. But it's really important for people to know that even kidneys with a higher KDPI score, maybe from older donors or those with some health issues, still offer a significant survival benefit compared to staying on dialysis. They're still valuable gifts.
That's a really important point. Okay, so donor type is one thing. What about the actual matching? Making sure the recipient's body is less likely to attack it immediately. Is it like finding a twin?
Not quite an identical twin, but we try to get as close as possible on key factors. The basic requirements are ABO blood group compatibility, just like with a blood transfusion.
Right.
And then a cross-match for something called human leukocyte antigens, or HLA. These are those ID badges on the cells we talked about. The closer the HLA match between donor and recipient, the lower the risk of immediate strong rejection.
But finding a perfect match must be hard.
It can be, especially for some people. But we've had amazing breakthroughs here. For instance, a treatment using intravenous immune globulin, IVIU, was FDA approved back in 2004, has been a huge help. It can actually help desensitize patients who have antibodies against many potential donors, making it possible for them to receive a kidney that isn't a perfect match. It's opened up transplantation for many who were previously considered almost impossible to transplant.
That's incredible. A real game changer.
Absolutely.
Okay, so the match is found, the organ is available. What happens during the actual surgery? Where does the new kidney go? Is it complex?
The surgery itself, in terms of placement, is fairly standard now. The new kidney isn't usually put where the old ones are. Instead, it's typically placed lower down in the abdomen, in a spot called the iliac fossa.
Oh, interesting. So they don't take the old ones out.
Usually not. The patient's own kidneys, even though they're failing, are generally left in place unless they're causing problems like infections or high blood pressure. Taking them out adds extra surgical risk.
Makes sense.
The surgeon then connects the new kidney's artery and vein to the recipient's large iliac artery and vein down the pelvis. And the ureter, the tube that carries urine from the kidney, is connected to the bladder.
And surgery techniques have improved too, I imagine.
Definitely. For living donors, the donation surgery is often done laparoscopically, minimally invasively, which means a much quicker recovery for the donor. And we've even seen the first fully robotic kidney transplants performed, which is really pushing the envelope on precision.
Wow. And what about keeping the kidney healthy between the donor and recipient? That seems critical.
Absolutely critical. We talk about two key time periods. Cold ischemia time is how long the kidney is kept cold, usually on ice in special preservation solutions like the University of Wisconsin solution. Keeping it cold slows down metabolism and damage. Then there's warm ischemia time. That's the time from when it comes out of the cold storage until blood flow is restored in the recipient, basically, the sew-in time. Minimizing both is important.
Is there newer tech for this?
Yes, machine perfusion is becoming more common. It's sometimes called the kidney pump. Instead of just sitting on ice, the kidney is put on a machine that continuously pumps cold preservation fluid through it. Studies show this can improve outcomes, especially for kidneys that might be considered higher risk, and it can even help assess the kidney's quality before transplant.
Fascinating stuff. Okay, surgery's done, new kidneys in. What's the immediate recovery like in the hospital?
The typical hospital stay is somewhere between 4 and 10 days, usually. It's a period of really close monitoring.
And does the kidney start working right away?
It varies. Kidneys from living donors often wake up pretty quickly, maybe reaching normal function in 3 to 5 days. Kidneys from deceased donors can sometimes take a bit longer, maybe 7 to 15 days. Sometimes a patient might even need dialysis temporarily after the transplant while waiting for the kidney to kick in fully.
And what are the potential bumps in the road right after surgery? Complications.
Well, like any major surgery, there are risks. Bleeding or hemorrhage is one. Another serious one is thrombosis, a blood clot forming in the new kidney's artery or vein. You can also get a lymphocele, which is a collection of lymphatic fluid near the transplant site.
Okay, surgical issues. What else?
Infections are a big one, especially in the first few months when immunosuppression is typically strongest. Common things like UPIs or wound infections, but also those opportunistic infections we mentioned, CMV, EBV, BK polyomavirus. That BK virus is particularly concerning because it can directly harm the transplanted kidney.
So they give preventative meds.
Yes, often patients receive prophylactic antiviral and antibiotic medications for a period after transplant to try and prevent these infections.
And rejection is still a risk, even right after.
Absolutely. There's something called delayed graft function, DGF, which is when the kidney doesn't work well initially and needs dialysis in the first week. And then there's acute rejection, which can happen anytime, really. It's graded using a system called the Banff classification, and it can be driven by T cells, antibodies, or both.
And what causes rejection then?
Often it's related to the immunosuppression. Either the levels aren't quite right, or unfortunately, sometimes patients struggle with adhering perfectly to the complex medication schedule. That non-adherence is a really significant factor in rejection episodes. It highlights just how crucial that lifelong commitment is.
Right. That commitment brings us to the next big area. We've talked about the science, the surgery, the risks. But what does this all actually mean for someone's daily life? Living with this transplant? Is it just back to normal pre-illness life?
You know, it's really interesting. The research, especially the studies talking to patients, describes this fascinating dual character of life after transplant.
Dual character. How so?
Well, on one hand, there's this incredible sense of freedom and a return to normalcy, or at least near normalcy. Patients talk profoundly about being liberated from dialysis, regaining control over their time and lives.
I could really imagine.
They report feeling younger, having much more energy, being able to travel, work, socialize, play sports, things that were difficult or impossible before. It's a huge improvement in quality of life, a feeling of getting their life back.
That sounds amazing. What's the other side of the duality?
The other side is this persistent sense of bodily vulnerability. It's not quite a full return to how things were before they got sick. There's the reality of lifelong dependence on medication. There's the need for constant self-monitoring blood tests, checking for symptoms, adhering to dietary rules, fluid restrictions sometimes.
You're always aware.
Always aware. And the side effects of the drugs themselves, things like weight gain, maybe facial puffiness from prednisone, hair changes like loss with tacrolimus or extra growth with cyclosporine. These are constant physical reminders that their body state is altered. It makes them feel vulnerable, different.
So physically, it's a mix. What about emotionally? Is it just pure relief and gratitude, or is that mixed too?
Oh, it's definitely a very complex emotional cocktail. Huge positives, absolutely. A lot of hope for the future, sometimes a new perspective on life, a stronger sense of purpose, and deep, deep gratitude towards the medical team, family, and especially the donor. You hear about people celebrating their giving day or transplant anniversary like a second birthday.
It's lovely.
It really is. But alongside that, there are often significant negative emotions too. Fear and uncertainty are big ones, wondering, how long will this kidney last?
That must weigh heavily.
It does. There can also be profound guilt, especially towards living donors, feeling indebted, or guilt towards their own families, feeling like they've been a burden. Frustration with the side effects is common, and the financial stress, ongoing medication costs, checkups that can be a huge source of anxiety. Worrying about future health, ability to keep working, that's a lot to carry.
Yeah, it's definitely not just fixed and done. How does all this impact their social world, their relationships? Does it bring people closer, or can it create distance?
Again, you see that duality. Some patients actually report feeling social isolated afterwards. They might feel that only other transplant recipients truly get it. They might lose touch with friends they made during dialysis. Relationships can sometimes be strained by the ongoing health focus or the emotional roller coaster. But on the other hand, many also describe developing what one study called an intimate society. They form really close, trusting bonds with their transplant team. Doctors, nurses, coordinators become like extended family. And often, family ties are strengthened. Being able to fully participate again in family life, in social events, without being tied to dialysis schedules or feeling terribly unwell, that's a massive gain for relationships.
That makes sense. It reconnects them.
Exactly.
Huh.
But there's a caveat here, too. Patients often talk about gaps in the support they receive.
Oh.
Things like feeling they don't get enough clear, practical information on how to manage everything after they leave the hospital. Sometimes getting conflicting advice from different medical professionals, which is confusing. And a big one is the lack of long-term psychological support to help navigate all those complex emotions we just talked about. Concerns about cost and access to ongoing care can also create distrust or anxiety.
So the support system isn't always perfectly aligned with their needs.
It seems not always, based on what patients report.
What really stands out listening to all this is how incredibly proactive and knowledgeable the recipients themselves have to become. It sounds like that they basically have to become experts in their own condition.
They absolutely do. Self-management isn't just important, it's critical for the transplant's success. It becomes, in many ways, a central part of their life. They develop these amazing coping strategies, focusing on adapting, on recovering, on staying well.
So what does that self-management look like day to day?
It's meticulous adherence to the medication schedule, knowing exactly when to take each pill, understanding potential interactions, never missing a dose as possible. It's constant symptom monitoring, being attuned to subtle changes in how they feel, their urine output, their weight. It's learning to adjust to the physical and emotional ups and downs.
And lifestyle changes too.
Huge lifestyle component. Health promotion becomes just how they live. Things like ensuring they drink enough fluids, definitely quitting smoking, being super careful about sun exposure because of the increased skin cancer risk from the meds, following dietary guidelines, getting regular exercise.
Can you give some really practical examples? What are they told to watch out for?
Yeah, the patient handbooks are very specific. They'll say things like, call your transplant coordinator immediately if you miss a dose of your anti-rejection meds, if you can't afford your medication, if another doctor prescribes you any new medication, if you have a positive pregnancy test.
Okay, very clear triggers.
Very clear. Also, physical signs. Gaining more than, say, 3 pounds in 24 hours, heart rate going too high or too low, producing less urine than usual, new fatigue, any pain over the transplant site, developing a fever, or any new swelling. These are all red flags they need to report right away.
It's constant vigilance.
It really is. And it extends to things like food safety, only drinking treated or filtered water, washing hands obsessively, rinsing fruits and vegetables thoroughly, refrigerating leftovers quickly. Even dental care needs special attention. Always tell the dentist you're a transplant patient, maybe wait 6 months post-transplant for major work, take antibiotics before procedures if advised.
Wow, anything they absolutely have to avoid.
Yes. Herbal supplements are generally a no-go. Probiotics often aren't recommended either, though herbal teas are usually okay. But the big ones they hammer home are grapefruit, pomegranate, and green tea products. Not just the occasional cup of tea, but extracts or supplements.
Why those specifically?
Because they are known to interfere quite significantly with the metabolism of some crucial anti-rejection drugs, particularly tacrolimus, cyclosporine, and sirolimus. They can dangerously raise the levels of these drugs in the body.
Okay, so even common, seemingly healthy foods can be risky.
Exactly. It really underscores that 247 commitment needed to protect that precious gift.
So we've really taken a deep dive today into kidney transplantation. We've seen it's, well, a true medical marvel, offering this incredible chance at renewed life, freedom from dialysis.
A liberation.
But it's also clear it's an incredibly complex and demanding journey. It requires constant vigilance, this profound adaptation, and just immense emotional strength from the person living with the transplant.
That's very well put. It's biology, but it's also so much psychology and sociology wrapped up in it.
Exactly. And it seems like despite all the amazing scientific progress, the long-term success, the thriving with the transplant, hinges just as much on the patient's ability to navigate all this self-management as it does on the biology of acceptance, and maybe just as much on the strength of the support systems around them, medical, psychological, social.
That connection seems crucial.
It does, which leaves us with a thought, maybe for you, the listener, to ponder. Given everything we've discussed, how can we, perhaps as a society, better ensure that this incredible gift of a new kidney truly translates into a gift of a full, well-supported life? where that idea of tolerance isn't just immunological, but really encompasses the person's entire well-being.
That's a powerful question to end on. How do we support the whole person, not just the organ?
Something to think about.